طيب السلام عليكم. Today we will mark our 11th lecture in our initiative, Unity Through Knowledge, the collaboration between SUDAC and Anesthesia Board from Sudan. Today we will host Dr. Osman Alselimi. He's one of our consultants in Hamad Medical Corporation. Dr. Osman Alselimi or Osman Ahmed is the deputy section head for Al Khor Hospital. And he has a lot of achievements in terms of research, in terms of education, in terms of simulation. He's on the examiner faculty of our residency program and Qatar board. Without any further ado, I will introduce Dr. Alselimi to take the floor and to start a neuromuscular blocker and reversal. Today is the second session on the pharmacology series. So the floor is yours, Dr. Osman. Take over.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله الأمين. السلام عليكم ورحمة الله وبركاته. And thank you. شكرا دكتورة حياة، شكرا دكتور خالد، والشكر دكتور ايناس، دكتور سهيل، ورابط الأطباء في قطر. السلام عليكم to all attendees. إن شاء الله يعني كلكم تكونوا بخير وأهلكم، نسأل الله إنه يلطف بالسودان ويخفف ويفرج على كل أهلنا في السودان في كل أنحاء السودان إن شاء الله. Thank you, Dr. Hayat, for the introduction. Today our lecture will be about the neuromuscular blockers or muscle relaxants. We will be using this name interchangeably, but they mean the same thing. So in the next 1 hour or so, we will be talking about this topic. Unfortunately, the topic it's very basic, so it might be a little bit boring. However, it is one of the most important tutorial maybe you need to attend, because simply neuromuscular blockers or muscle relaxants is a topic kind of solely for anesthetists, and you are, as anesthetist, you will be maybe the only person among the team who know about these drugs, how to use them, how to manage them. So a thorough knowledge about those drugs, their physiology, their pharmacology is very important and paramount, and one of the kind of safety features for your practice. So we will kick off. I should say that I have no conflict of interest with this presentation, and it's solely for educational purpose. By the end of this tutorial, you will be able to discuss the basics of pharmacokinetics and pharmacodynamics of muscle relaxants or neuromuscular blockers and reversal agents. You will be able to safely deliver and manage these drugs and muscle relaxation as one important step in your anesthesia care or intensive care. And you will be able to sufficiently monitor patients and their neuromuscular blockage. So we will try to make it as nice, as digestible as possible for you to take a nice message to the home and make use of this 1 hour, inshallah. So in terms of history, the arrow poison used by the Amazon Indians during this era of 1811 to 1878 marked the start of the muscle relaxation, as they used the arrow bison curare to hunt animals. And then subsequently in 1935, that when Harold King identified the chemical structure of that compound, which is curare, which they use it in those hunting business. And then it came to 1942 when Harold Griffith and Enid Johnson used a purified extract of this curare in clinical settings, and they use it in a patient undergoing general anesthesia. Succinylcholine, which was the kind of a mark step in the development of neuromuscular blockers, was sensitized in 1906, but it was until 1951 to 52 when it was introduced into clinical practice. And then subsequently after that, they discovered the different structure between succinylcholine and curare, and that marked the beginning of the differentiation between depolarizing and non-depolarizing muscle blockers. And then after that, the second or the first kind after the curare, the pancuronium, was discovered in 1967. So why we use neuromuscular blocking drugs or muscle relaxants? Actually, we use it for so many reasons, but probably the most important is to provide temporary paralysis, to facilitate the insertion of the intratracheal tube in the anesthesia practice and ICU, to improve operative condition. I have to say that improving the operative condition, there is lots of talk in the literature whether the muscle relaxant will improve the operative condition or not. But the introduction of the minimally invasive surgery and laparoscopic procedures kind of push towards the positive attitude of the feeling that muscle relaxant improve the operative condition. We use it as well to facilitate mechanical ventilation and decrease the oxygen consumption in the intensive care unit, and to attenuate the rise in intracranial or intrathoracic pressure that might result from suctioning or coughing when we do procedures, especially for patients in critical care. We use it as well to prevent the motion during therapeutic and diagnostic maneuver, and we all know about the electroconvulsive therapy and these kind of therapeutic procedures. We use it as well to prevent self-injury in cases of seizures and abnormal movements. It is very important as well for us to know about the physiology of the neuromuscular junction. That is the place where those drugs work before we can identify the effects and the side effects of those neuromuscular blocking agents. So the neuromuscular junction it forms a chemical bridge between the motor neuron and the skeletal muscle. And you can see from the diagram that the axon to the alpha motor neuron is myelinated, but the small distal part of it is unmyelinated. That's where it kind of approximates to the neuromuscular junction. So it is a chemical bridge, and the postsynaptic membrane, as you can see, has many folds, and the shoulders, they contain the acetylcholine receptor, while the clefts contain the acetylcholine esterases. The acetylcholine, when the kind of the natural neurotransmitter at the neuromuscular junction, when it is formed, it contains in a small synaptic vessels, and it is stored just pre-synaptically and ready to go. When the action potential starts or triggers, then the influx of the calcium kind of stimulate the release of acetylcholine. However, once the acetylcholine starts its action, the acetylcholine esterases, the natural enzymes that degrade the acetylcholine are there, and they degrade the acetylcholine within 1 millisecond after its release. So you can imagine that the acetylcholine potentiates the muscle contraction, but it is very quickly degraded by the acetylcholine, which are kind of neighbor to it. So they are very close proximity to it, and they inhibit it, and then the action potentially start again and again. So it is important also to know about the acetylcholine receptor. And these are integral membrane proteins, but they have 5 subunits. They have 2 alpha, single beta, epsilon, and gamma. So there are 5 subunits, but we'll be more interested in the 2 alpha subunits. That's where the acetylcholine and all neuromuscular junction, neuromuscular blockers or muscle relaxant bind. So the postsynaptic, that's where the muscle relaxants or the neuromuscular blockers bind, but there is again a pre-junctional membrane receptors. And as we will see later, these are mainly responsible for the fade in the when we come to the management and monitoring of the neuromuscular blocking. These receptors, they have a central ion channel that opens when the alpha subunit bind to the acetylcholine, or of course, other muscle relaxants. And the quaternary nitrogen group of the acetylcholine and all other muscle relaxants, they bind to the alpha subunits. And basically binding the first alpha subunits will increase the affinity for the second alpha unit to bind the other molecule of the acetylcholine on both sides. I have to say that those receptors, they are non-specific, those they allow potassium, sodium, and calcium across the membrane. And they will generate a small amount of end-plate potential that at some stage will submit together to reach a threshold. That time, then the voltage-gated sodium channel will open and a rapid depolarization will happen in the neuromuscular junction. Then when the action potential reaches the T-tubular, then the calcium will be released from the sarcoplasmic reticulum and initiate muscle contraction. These all are kind of very basic terminologies, but I just include them so that you understand the action of those muscle relaxants, because that will kind of be the basis of the effects and the side effects of the muscle relaxants. As I said, acetylcholine is the natural transmitter in the neuromuscular junction, and it is important to know about the kind of structure of acetylcholine. And acetylcholine is sensitized from acetyl coenzyme A and choline. The choline usually comes from either the diet or it will be recycled from the breakdown of acetylcholine by acetylcholinestases. Okay. So the acetylcholine structure will form the basis for the muscle relaxant as we see in the journey of their synthesis historical wise. It is important also to relate the structure of the neuromuscular blocking drugs with the activity, because all of those muscle relaxants are quaternary ammonium compound, and as I said, they are structurally related to acetylcholine, and they contain this quaternary nitrogen group that is very important. And structurally, we can differentiate them into 2 categories, which is bis-quaternary or monoquaternary. And from the name that you can understand that the bis-quaternary will be more potent than the monoquaternary. Bis-quaternary, things like succinylcholine, the pancuronium, and atracurium. And the monoquaternary like rocuronium and the bicronium. So they are kind of weaker than the bis-quaternary, because the bis-quaternary, they will attach to the 2 alpha subunit of the acetylcholine receptor. However, the monoquaternary structure, they have their amine group might become protonated, and therefore it will become positively charged, especially in situation of inflammation and infection. The 2 ammonium group then will be separated by a bridging structure, and that is lipophilic in nature, and that will determine the potency of each and every muscle muscle relaxant. Okay, so muscle relaxants, usually they cause muscle paralysis. As we know, we will see in few times how they do that and how we can classify them based on that one. So our all kind of talk about the muscle relaxants will be mixed between pharmacology and physiology because it's kind of a mixture of compounds that interact with receptor with a chemical transmitter. So you have really to kind of appreciate all those factors when you come to understand the action of the muscle relaxants. So basically, as we said, they block the function of the postsynaptic acetylcholine receptor, as we see in the previous diagram. They have, as we said, at least one quaternary amine group. They might have two, which is the bis quaternary. And this quaternary amine group will be involved to bind the subunit of the nicotinic acetylcholine receptors. And binding to one will induce either agonistic or partial agonistic or an antagonistic activity. Okay, so acetylcholine is the natural transmitter at the neuromuscular junction, and this is the natural agonist. And obviously, the effect of it will be it will induce the contraction. Then we have the two groups of muscle relaxants, which is the depolarizing and the non-depolarizing. So the only depolarizing muscle relaxant is the succinylcholine, and obviously the non-depolarizing will be divided into other compounds, as we will see later. But at this stage, I want you to understand that the acetylcholine is the natural agonist, and it makes contraction of the neuromuscular junction by interacting with the acetylcholine, by attaching to the alpha subunit of the acetylcholine receptor. While succinylcholine, as we will see, it's two molecules of acetylcholine. Succinylcholine is a two molecules of acetylcholine joined together, so we consider it as a partial agonist. And what it does, it does in the same way of the acetylcholine, but the only difference is that succinylcholine is metabolized by plasma cholinesterases, which are not available at the neuromuscular junction. So it will take time for the action of the succinylcholine to terminate. It's not like the acetylcholine. So the muscle will remain flaccid for some time until succinylcholine move away from the neuromuscular junction, and then subsequently it will be metabolized in the central compartment by the by plasma cholinesterases. What succinylcholine does, it does what we call a non-competitive block and paralysis. However, if succinylcholine concentration is increased at the neuromuscular junction by either a second dose of succinylcholine or a reduced action of plasma cholinesterases, this will take us to a phase 2 block. We will know in a minute the characteristic of each block. That's also kind of very important. I know it's very basic. It might feel a little bit boring and difficult, but it is really very important to appreciate those ones, because once you understand them, application in a clinical setting will be more easier. So let us just agree on this one. So succinylcholine is a partial agonist, and what it does a non-competitive block. Okay, if the concentration increased by a second dose of succinylcholine or a reduction in the metabolism of succinylcholine, the concentration will increase in the neuromuscular junction, and it will take us to phase 2 block. All other muscle relaxants, which is the non-depolarizing muscle relaxants, they will act as an antagonist. And what they did a competitive block. So they attach to the alpha subunit of the acetylcholine receptor and they prevent the action of acetylcholine. I mentioned phase 2 block here because phase 2 characteristic will be different from the basic succinylcholine action, and it will approximate more towards the competitive block of the depolarizing muscle relaxant. Okay, so from here we agree that we have a group of drugs, which we call them muscle relaxants or neuromuscular blocking drugs, and we divide them into two main groups, which is depolarizing and non-depolarizing. The only depolarizing muscle relaxants available is the succinylcholine. Okay, succinylcholine is a partial agonist because it's very similar to acetylcholine, while the other non-depolarizing muscle relaxants, they have the quaternary or bis-quaternary group, and they attach to the alpha subunit of the acetylcholine receptor, but in a competitive manner to acetylcholine. Okay, so we will go through the kinetics of those muscle relaxant. Kinetics means probably from the previous lesson, you know that the pharmacokinetic is what the body does for the drug. So how the body handles the drug, or what elements related to the body, to the blood, to the age affect the metabolism of those drugs or handling of those drugs in the body. And then subsequently, we will talk about the pharmacodynamic, the effects and the side effects of those drugs. Okay, so the muscle relaxants are usually administered intravenously because they are not absorbed from the GI tract. However, you can give the desired paralytic effects through the subcutaneous or intramuscular application. And basically, the earlier discovery of the poison arrow was the kind of it goes intramuscularly. However, you have to use a large dose of muscle relaxant to achieve the same block through the intramuscular route. Succinylcholine, however, sometimes it's given as intramuscularly in terms of emergency cases when the IV line is not available. So you can give it as an intramuscular route, but it is kind of the kinetics will be kind of different when you give it as an intravenous. We have to say that all muscle relaxants are positively charged quaternary ammonium, so the lipid binding is nil or very less. So this will affect the volume of distribution. So the volume of distribution is very small, and it is exclusively in the extracellular space. However, during prolonged infusion, some intake into peripheral compartments might happen, and it will increase the elimination time of those drugs. They bind to plasma proteins, particularly albumin and globulins, and usually this will kind of reduce the available drugs to be available in the effective site. There is another during inflammation, alpha acid glycoprotein also will come into action, and it will result in a decreased free fraction of those muscle relaxant in the plasma. So their action will be reduced. So you can imagine that if you want to apply this one clinically in a situation of inflammation and infection, you might need a larger dose of muscle relaxant. So in terms of potency of muscle relaxants is usually described by their affinity to the acetylcholine receptors. So in terms of potency, there is kind of an interesting things about muscle relaxant. That is they exhibit or they show what we call a reciprocal relationship between the pharmacological potency and the onset time. That is to say, if a low affinity drug require a high dose, So it will require a high effective dose 95 to achieve a defined twitch depression or kind of neuromuscular block. Then the concentration gradient between the central compartment and the effector side will be high. This will resulting in a faster delivery of the drug to the receptor, and then it will increase or reduce the onset time. And this is the basic, and the vice versa is true. So in terms of a drug which is kind of have a high potency, we usually give it in small amount, or a small dose. So the transfer between the central compartment and the neuromuscular junction will be slow. So it will have a slower onset time. But the first example will be typically applied to rocuronium, as we will see later, because it is kind of a low potency drug and we give it in a high dose. So whenever we give it in a high dose in emergency cases, so we reduce the onset time pretty much, and we will have a faster intubation condition. If you give a fast injection, then this will generate a concentration gradient between the central compartment and the biophase or the effector side, the neuromuscular junction, and then it will increase the onset time as well. Regional blood flow as well will affect the kinetic of those drugs in terms of onset time and specific muscle groups which will have paralysis first in comparison to other muscles. In terms of obesity, it's kind of very important to appreciate the kinetics of those muscle relaxants in relation to obese patient, because body weight related volume of distribution and clearance in obese patient is markedly reduced if you compare them to normal patients. So you have to appreciate that obese patient, their volume of distribution is pretty much less. And already we have a smaller volume of distribution for those kind of drugs. Pregnancy is kind of affecting the kinetic of those drugs in terms of if the patient kind of taking, obviously in terms of the body volume and these kind of things also will affect to some degree. But most important, if the patient is taking magnesium, magnesium is one of the drugs which kind of potentiate the action of muscle relaxant, and you have to take that one into consideration. In terms of materno-placental transfer is very limited because those drugs are polar and positively charged. So the transfer will be very limited unless the patient have a prolonged infusion of those muscle relaxants that will affect the kinetics in terms of elimination and so forth. Temperature also affect the kinetics, and the hypothermia will delay the metabolic breakdown in terms of hepatic and renal clearance, as well as the Hoffman degradation process, specifically to isoquilinium non-depolarizing muscle relaxant, as we will see later. Age, volume of distribution is larger in children compared to adults, and they have, so in children, a higher dose maybe of muscle relaxants will be needed to achieve a given concentration of relaxant. So you have kind of, again, to appreciate that one. In terms of the metabolism and elimination also might be affected by age, but that is basically will be related to the organ or organ damage or organ kind of function related to age as in advanced age. So the elimination will be the most important thing. And as I said, some of the drugs will affect the kinetic and they will potentiate the action of muscle relaxant. This, beside magnesium, you can think about things like the volatile anesthetic, aminoglycoside antibiotic, quinidine, tricyclic antidepressant, ketamine, midazolam, and barbiturate. This all will potentiate the action of muscle relaxants. So this is kind of briefly about the kinetics of the muscle relaxants. You take it in the sense that they are polar compound and they are kind of very restricted to the extracellular compartment. Their lipid solubility is very limited. They bind to proteins. In terms of infection and inflammation, protein binding might increase, and this will reduce the free drug available to reach the neuromuscular junction. You have to consider things like obesity, pregnancy, age, and temperature in terms of the kinetics of those drugs when you use them in clinical situations. So we will talk a little bit about succinylcholine, which is the only depolarizing muscle relaxant available. Despite the use of succinylcholine has reduced largely recently, but still it is there. And it is kind of used in some situation despite the replacement by recronium. Succinylcholine basically is the two molecule of acetylcholine bound together, and it retains the depolarizing capacity of acetylcholine. But as we said, it's not hydrolyzed by the acetylcholine esterases. So it has to diffuse back from the neuromuscular junction to the central compartment to be degraded by plasma cholinesterases. So it will take time in the neuromuscular junction. And as you can see from the structure, it's just quite similar to acetylcholine. And as we said, it is a partial agonist at the neuromuscular junction, and it can cause phase 2 block if the concentration, if you give a second dose of succinylcholine, or the plasma cholinesterase effect is less and there is a large amount of succinylcholine available at the neuromuscular junction. So basically, it elicits an initial depolarization, and the thing which is kind of quite specific to succinylcholine, it causes fasciculation, kind of a small contraction of the muscle. And that we call it kind of fasciculation. And it has something to do also with the pre-junctional acetylcholine receptor. And the two quaternary ammonium, they bind to the 2 alpha subunits of one nicotinic receptor, and then depolarization will happen. Will correspond to phase 1 block. So they first open, and then as you can see in the diagram between A and B, so it's kind of voltage gated and time gated. So they open and sodium enter, and then it close and it become inactivated. Okay, and then so it become flaccid. The muscle become flaccid, and until succinylcholine is moved away from the neuromuscular junction, and that will take time or kind of few minutes by the time the concentration gradient reverse. So it comes from the central compartment to the neuromuscular junction, and once the concentration gradient reverse, it will go back to the central compartment where it is degraded by plasma cholinesterases. Fasciculation is something very important, and you can see it clinically. Probably most of you have seen it. And it's kind of a result of action of succinylcholine in the pre-junctional acetylcholine receptor. As we said, prolonged exposure of the neuromuscular junction to succinylcholine then will result in phase 2 block. And phase 2 block in terms of monitoring of train of 4 and post-tetanic count, as we will see later, it simulates the block produced by the non-depolarizing muscle relaxant. So succinylcholine historically has made a significant advantage over the muscle relaxation, because it produces a profound muscle relaxation in a very short duration. And you need it really in our current practice, like for rapid sequence induction, or some people they use it still for cesarean section, category 1, or those kinds. Although the replacement by rocuronium have reduced the use of succinylcholine. It is presented as a colorless solution and containing 50 milligram per ml and should be stored at 4 degrees Celsius. The dose for tracheal intubation is around 1 to 1.5 mg per kg, and the profound block will be reached at 60 seconds, but probably from 30 seconds you will be able to intubate the patient, and then it might take start to wear off from 3 minutes, and it might be complete within 12 to 15 minutes. So this kind of this information sometimes is quite important to know, especially for those who are doing the exams, because these kind of small things usually they come in the paper question or in the Viva question. So despite the kind of the big advantage succinylcholine has made in the anesthesia practice in terms of muscle relaxation, it has lots of undesirable or side effects. And this also kind of a rich area for exam questions. And clinically also, you really need to know them very well, because sometimes it might be very detrimental to use succinylcholine in a patient susceptible for those undesirable side effects. On the top of the list will be bradycardia, and this is kind of basically the effects of succinylcholine on the muscarinic receptors in the sinoatrial node, because so it's a phenylytic, so the muscarinic receptors, and then it produces bad tachycardia. Sometimes you need to use atropine to treat it. Okay, muscle pain also is kind of quite significant. If any of you have had succinylcholine himself or herself, will never kind of forget that one. And this is mainly due, as we said, to fasciculation and due to the action of succinylcholine in the pre-junctional acetylcholine receptors. And those kind of occur in the small muscles of the diaphragm, intercostal, and between the scapulae. So it is kind of very evident on those areas. It's quite common in the young. It's less in children and elderly and pregnant. You can treat it with pre-curarization. That's kind of giving a small dose, as we see later, of a non-depolarizing muscle relaxant. Increase muscle serum potassium. That's kind of very important side effects, and you have really to be very vigilant on that one, because normally succinylcholine, if you give to a normal person, will make an increase of 0.5 millimole per liter in serum potassium concentration, and in patient undergoing halothane anesthesia. This is kind of from literature, and this is again as a result of muscle fasciculation. But this response will be quite exaggerated in patients with bone, muscular dystrophies, paraplegia, prolonged immobilization, and this is due to proliferation of extrajunctional receptors. So that's kind of very important, and you have really to be very vigilant in terms of those side effects, and you have to be expecting to have them, and you should avoid succinylcholine in susceptible patients. Other things that you also could encounter with the succinylcholine is the increase in intraocular pressure. And succinylcholine 1 mg per kg will cause an increase of around 4 to 8 millimeter mercury in the intraocular pressure. And it also increases the choroidal blood flow and extraocular muscle tone and aqueous humor outflow resistance. So this is kind of very important, and it is kind of quite significant, especially in trauma patients with penetrating eye injury using succinylcholine could lead to expulsion of the vitreal contents. So they have to be, again, very vigilant and cautious about those side effects. Increasing intragastric pressure, again, could happen as well. And fasciculation of abdominal muscles will contribute to that one. Hypersensitivity, again, we know that we generally know hypersensitivity to non-depolarizing muscle relaxant. But however, succinylcholine cause hypersensitivity, and it causes type 1 IgE-mediated hypersensitivity reaction. And it basically, in the literature, it contributes to 50% of the hypersensitivity to muscle relaxant. Other non-depolarized also cause the anaphylactoid reactions. So these are kind of the side effects. And the remaining two serious one of side effects related to succinylcholine use is the malignant hyperpyrexia, because succinylcholine is the recognized trigger factor for malignant hyperthermia. And that's obviously, you must, every anesthetist must know about malignant hyperpyrexia in terms of recognition, susceptibility, how to treat, even if as a crisis, or how to treat patients with susceptibility to malignant hyperthermia coming for anesthesia. The other thing is the prolonged paralysis. So malignant hyperthermia probably is a different topic, but you really need to know about it in enough information. Prolonged paralysis, and this will be either due to reduced plasma cholinesterase, which break succinylcholine in the blood, and that will be as a result of genetic or acquired factors. The genetic conditions usually are due to a single amino acid substitution on chromosome 3, and the 4 allele. Usually you will hear about EU. So U is kind of normal, EA is a typical one, ES is a silent, EF is a fluoride. So this kind of, you will find them in lots of exam questions. So the normal one, or the DBUK resistant, or the atypical, this is the atypical gene, the DBUK resistance, because we will see in a minute how the effect of DBUK on those one, and the silent gene, and then the fluoride resistance. 96% of the population are homozygous for the normal gene, which is EU. Okay, so the remaining 4%, so those normal, they metabolize succinylcholine or succinylcyanium rapidly, and up to 4% they might be heterozygous, different combination of the gene, and they this will result in a mildly prolonged succinylcholine apnea. It might go up to 10 minutes above the normal metabolic time, while a very small fraction of this 4% will have a genotype that confers a block for few hours, and this is usually the atypical gene. The other acquired factors which kind of affect the breakdown of succinylcholine are pregnancy, liver disease, renal disease, cardiac failure, thyrotoxicosis, and cancer, because all these conditions reduce the availability of plasma cholinesterase. The WK number is kind of something very important terminology, and you will find it lots. And WK basically is a local anesthetic, but when they put it to the plasma cholinesterases, it inhibits the normal plasma cholinesterases. So it inhibits the normal plasma cholinesterases, the EU, by 80%, while they inhibit the atypical gene by only 20%. And then they inhibit different combination in between 20 to 80%. So it came as a Debucane number, which is indicate the percentage inhibition of the plasma cholinesterase. And that is just indicate the genetic makeup of the patient. So you will see the Debucane number. You can see from the table the EU, the normal gene, which is the duration of the block is normal. The incidence, as I said, it will be around 96% of the population will be in this category, and the Debucane number is 80. So these people, they metabolize succinylcholine normally, and the block will wear off in kind of a normal time. While the atypical gene, which is kind of the duration of log, will be very prolonged, and the Debucane number is only 20, and then the others will be in between. Okay, so we will, this is succinylcholine, and then the other category is the non-depolarizing muscle relaxants. Those ones are generally classified into two main categories based on the structure of those compounds. They will be divided into amino steroid compound or benzyl isoquinone. So amino steroid, things like becronium, procronium, obviously maybe the commonly used among them, and benzyl isoquinone compounds like atracurium. Another classification, you can classify them by the duration of action, which is kind of short duration of action, intermediate like atracurium, or long like the ban curonium. Okay, so this is kind of just the classification. It's a duplicate slide. Okay, so these are the commonest. So obviously there is other non-depolarizing muscle relaxants. Kind of recently, some of them are in the US or the UK, but these are the commonly used, and you will find them in most of the hospital you work, though, either in Sudan or outside. Okay, so the mechanism of action of the non-depolarizing muscle relaxants, as we said before, they are quaternary ammonium. They have similarity to structure of the acetylcholine, and they antagonize the action of the acetylcholine in a competitive manner. Okay, and once they bind to the alpha subunit, this will prevent access of acetylcholine to the postsynaptic nicotinic receptor. So it's a competitive nature of block. Usually there is a wide safety margin in the neuromuscular blocker, and 70 to 80% of the receptor will need to be occupied for the block to be evident. So it's kind of really, you need a higher receptor occupancy to have a muscle relaxation. 92 of the receptor must be occupied to produce a complete block, and blocking of the pre-junctional receptor will result in failure of mobilization of acetylcholine. So when they block the pre-junctional receptors as well, that this will further deprive the neuromuscular junction from acetylcholine, and it will prolong the flaccidity of the muscle. Okay, pancuronium is one of the amino steroidal compound. It's a bisquaternary. It's kind of we said before, the bisquaternary are kind of more potent than the monoquaternary. It is presented as a colorless solution, contains around 4 mg in 2 mL, and again, it should be stored at 4 degrees Celsius. The intubating dose is around 0.1 mg per kg, and this will give you intubating condition in around 90 to 150 seconds. Duration of action is 45 minutes around. 10 to 40% is plasma protein bound, so it is one of the one of the relaxant which has a higher protein binding. It has a low volume of distribution, similar to all other muscle relaxant because they are not lipid soluble. And it's usually metabolized in the liver by deacetylation to 3 and 17 hydroxy and dihydroxy pancuronium. Of note that pancuronium causes tachycardia by blocking the cardiac muscarinic receptor, so it has a muscarinic effect, an indirect sympathomimetic action by preventing the uptake of noradrenaline and postganglionic nerve ending. So it has kind of a cardiovascular effect. And one of the metabolite, which is 317 hydroxypancuronium, is half potent as pancuronium. So this kind of also will make it to the long duration of action of pancuronium. Vicronium is a monoquaternary analog. It's unstable in solution, so it is presented as powder or freeze-dried powder with mannitol and sodium hydroxide. The intubating dose is 0.1 mg per kg, and it has a medium duration of action. It is again metabolized in the liver by deacetylation to 3 and 17 hydroxy and 317 dihydroxy vicronium. Vicronium generally is famous as the clean drug because it doesn't have cardiovascular effects. It doesn't also precipitate the release of histamine. Compared to pancuronium, it is more lipid soluble. However, there is kind of a report about critical illness myopathy associated with vicronium. But usually vicronium, you will find sometimes each hospital, they have their own kind of muscle relaxants. They commonly use, okay, they use others, but usually they use one of them. This might be due to whatever budget in the hospital or whatever, but usually during my work, either in Ireland or somewhere else, usually you will find them, they use one specific muscle relaxant, most of the people, if not all. Okay, but vicronium, yeah, is famous as a clean drug because of the very less cardiovascular effect, and it is in powder chain because it's unstable in solution. Procronium is developed from vicronium, and it is an amino steroid, and it is different from vicronium only in 4 position structure wise. Okay, rocronium now is kind of used. It is less potent, so it is given in a higher dose. So giving it in a higher dose will increase the transfer between the central compartment and the neuromuscular junction. So you will have the onset time will be reduced pretty much. So it is fast acting. Okay, so we give it at 0.6 mg per kg, and incubation condition could be reached in around 100 seconds. Also, if you want to reduce that one, then you can give it in a higher dose, 0.9 to 1.2 mg per kg, when you are doing a rapid sequence induction or you need a faster incubation. Duration of action is similar to vicronium, so it's kind of a medium. It's mainly excreted unchanged in the bile and to a lesser extent in urine. So this kind of 3 examples about the amino steroid non-depolarizing muscle relaxants. Atracurium was kind of one of the famous muscle relaxant. Benzyl isoquilinium compound is formulated as a mixture of 10 stereoisomers, resulting from the presence of 4 chiral centers. Okay, so it contains lots of isomer. We will see cis-atracurium is one of those isomers of the atracurium. It is presented as a colorless solution containing 10 mg per ml in 2.5, 5, 25 vials, and should be stored at 40. So it needs fridge as well. Atracurium is very unique among the benzyl isoquininium because it has a unique metabolic pathway. It undergoes what we call ester hydrolysis and Hoffman degradation. So it is kind of very good for those patients who have liver or kidney disease. You want to avoid elimination through the kidney or the liver. To give atracurium will be very good because it's degraded based on the pH and temperature, as we will see shortly. Okay. The other thing about all benzyl isoquininium, they release histamine, and histamine might be localized to the site of injection, but could be also generalized, resulting in bronchospasm and hypotension. So you have to be also considering or appreciating the fact that benzyl isoquininium compound lead to histamine release compared to amino steroid. So you have pros and cons for each of the muscle relaxants, and you have to tailor it to your patient condition. Like if you, whatever, have a clinical scenario to choose between like atracurium and rocuronium, then you have to balance with the condition of the patient. Like atracurium will be metabolized just by Hoffman degradation, so you don't need really, even if the patient has kidney or liver failure, it's okay. And for atracurium, release of histamine will be there. So unstable patient might be affected due to can cause hypotension or bronchospasm or whatever, while rocuronium is an amino steroid, but it has to be metabolized through the liver and the kidney, and so forth. So the ester hydrolysis is non-specific esterases, and it accounts for around 60% of the atracurium metabolism, while Hoffman elimination is kind of it's a spontaneous breakdown of atracurium in the blood, and it produces lodanosine and quaternary monoacrylate. So this will be the products of the breakdown of atracurium. Lodanosine has been kind of mentioned in the literature. It might cause seizures in high concentration, but I don't think it's kind of clinically really very significant. I haven't seen it, and I haven't thought about somebody told me that one as well. But it doesn't have any neuromuscular blocking agent. So acidosis and hypothermia also will slow this process. Acidic condition could accelerate ester hydrolysis, and it might slow the Hoffman. So all these kind of interaction might affect the metabolic pathway of atracurium. Cis-atracurium is an isomer of the one of those 10 isomers present in the atracurium. Is again presented as a colorless solution. It contains around 2 or 5 mg per ml and should be again stored in the fridge with 4 degrees Celsius. It's 3 to 4 times more potent than atracurium, and it has a slower onset time because again, you see that the reciprocal nature of those, if it is potent, then the onset time will be slower or longer. It has a similar kinetic profile to atracurium, Hoffman elimination to lodanosine, and monoquaternary acrylate. So it's kind of similar because they are all benzyl isoquininium. All of its metabolite, they void of neuromuscular blocking agents, so they don't have any neuromuscular blocking agents. Mivacurium also, one of this group, is a benzyl isoquininium ester, and it is kind of again a chiral mixture of 3 stereo-specific isomers presented as an acidic aqueous solution. It contains 2 mg per ml in 5 and 10 ml ampule. The shelf life is 18 months when stored at 25 degrees Celsius. So again, storing it at higher temperature uh, might affect it. High doses may release the histamine. Again, it's because the benzyl isoquinonium, and that histamine release will be expected with it. It has a short duration of action. So that's kind of pretty unique to mivacurium. So for kind of daycare cases or cases which kind of short duration of surgery, you might need mivacurium will be kind of a good choice. Routine reversal with newstigmine may not be required as mivacurium is metabolized by plasma cholinesterase. So that's kind of also unique for the mivacurium. So you can use it for short duration surgeries, and it doesn't need newstigmine. Actually, histamine might prevent the metabolism because it inhibits the plasma cholinesterase. So, if you want to summarize this kind of the pharmacokinetics of the those agents in terms of protein binding, volume distribution, metabolism, and elimination, I just put this table. I will put all those references at the end of the presentation so you can maybe go back to them if you need to revisit again. But you can see we said that the pancuronium protein binding is more than others. Okay, but usually the protein bind is kind of not that much significant unless in a situation of inflammation, infection, glycoacid protein might increase and reduce the free drug available for neuromuscular junction. We said that the volume of distribution generally is very small and it's exclusive to extracellular space. Most of them are kind of metabolized to a large degree. Amino steroid usually will be excreted in bile and urine, and benzyl isoquinonium, like atracurium, they have the ester hydrolysis and the Hoffman degradation. So again, in terms of pharmacodynamic, we mentioned about the intubating doses of each of them. We said that rocronium usually will be given in a larger dose because it is less potent and that will speed up the onset time. So we use it as a substitute for succinylcholine for rapid intubation. Okay, all the rest kind of between onset will be around medium time. The duration, apart from the pancuronium, is very long, and the mivacurium is very short. The rest are all kind of medium. Most of them, they don't have significant cardiovascular effects, except for the histamine release that might kind of lead to hypotension and all. We said that pancuronium might cause tachycardia. The chronium generally is called as a clean drug because it has very less cardiovascular effects. And the histamine release is generally with the benzyl isoquinonium compared to amino steroid. Okay, so now we will come to a very important part, which is the monitoring of the neuromuscular block. That is very important, and it is something you really need to understand very well, because now monitoring of the neuromuscular junction is a must when you are using muscle relaxation. Okay, so monitoring the neuromuscular junction is important in the sense that you will know how much relaxes your patient and whether you need to give more relaxant or you don't give. So it's kind of a very objective assessment of the neuromuscular block and determine your action towards your patient during the surgery. Monitoring the neuromuscular block, usually we apply nerve stimulator, which generate a supramaximal stimulus. That will be in the range between 60 to 80 milliampere to ensure that all nerve fibers are depolarized, and then we will get some twitch For that twitch, we will identify the kind of the duration or the depth of the block. The duration of the stimulus usually is around 0.1 millisecond. The negative electrode usually will be placed directly over the nerve in question, while the positive will be placed somewhere else away from where it cannot affect the muscle in question. There are 5 buttons of stimulation, which is the single twitch, double burst, train of 4, post-tetanic count, and post-tetanic potentiation. So there is 5 buttons of stimulation the nerve stimulator will deliver, or now it is integrated in the anesthetic machine. So you just need to connect to the anesthetic machine where it will give you a display in the screen of the twitch based on the pattern you are stimulating. Okay. So the most famous one is the train of 4. It's kind of the most commonly used, a train of 4, and the post-tetanic count and post-tetanic potentiation. So we will talk about these 3 more than the others, but like 5 of them are very important. The train of 4, usually it will apply 4.1 millisecond stimuli delivered at 2 hertz. Okay. So you have to know it in that way. The machine is integrated, so you don't need to do anything in that one. You will just press the button for train of 4, and that will. But you have to know that it is kind of stimuli. It is 4 stimuli. Each of them duration is 0.1 millisecond, and each of them is 2 hertz. So from that one, we get 2 information. We get train of 4 ratio or train of 4 count. Okay, so the train of 4 ratio is the ratio of the. So there is 4 twitches. We'll see in a minute. But there is 4 twitches. So the percentage of the fourth twitch to the first twitch, that is will give you the train of 4 ratio. Sometimes it's very difficult clinically to appreciate that one, but the train of 4 count is also important because there are 4. So whether you get 1 or 2 or 3 or 4 of them. So that will be during the time between those twitches is again very important. So rapid stimuli will lead to a reducing twitch height in the presence of partial non-depolarizing muscle relaxant, and this we will call it the FADE. We will see in a minute. Usually, for the T4 to reduce inside, you will need a receptor occupancy of 70%. And that's we said that there is a large safety margin in the neuromuscular junction. When T4 is reduced or decreased by 25%, then T1 will start to decrease. Okay, that might be kind of very difficult to understand, but if you use it and look to the graph, you will appreciate that one pretty much. And when the T1 also starts to decrease, this will correspond now to 75 to 80% of receptor occupancy. See how large receptor occupancy will be needed to affect the train of 4. Then T4 will disappear totally. You will have 3 waves and 25% of its original height. Okay, so when T4 disappears totally, then T1 will be only a quarter of its original height. So they go like that in a sequential manner. Then if the receptor occupancy exceeds 90%, then T4 will disappear at all, and then it will reappear again. So the train of 4 is kind of assess the degree of deep neuromuscular block and recovery from the block as well. Let me show a graph in a minute so you will be more kind of familiar with it. Okay, the other one, which is kind of important to know, is the post-tetanic count and post-tetanic potentiation. So the stimuli is again 0.1 millisecond. Here you will give a large frequency, more than 30 hertz. Usually it is 50 hertz, and the twitches with this high frequency will fuse together to give you a sustained muscle contraction, which we call it the tetany. Okay, post-tetanic count, then uh, after the tetany happened, then you start after 3 seconds at 1 hertz tetanic stimulation. So you have to wait for 3 seconds and then start tetanic stimulation. The number of twitches then will be inversely related to the depth of the block. The more depth of the block, you will have less count of post-tetanic count. The partial non-depolarizing muscle relaxant and the tetanic stimulation fade with time due to the blockage. If you remember, we said because of the pre-synaptic acetylcholine receptor, the partial depolarizing muscle relaxant succinylcholine block will reduce, but it does not exhibit the fade. So the fade is not there unless, we said earlier, the type 2 block, phase 2 block is evident, where you have more of succinylcholine in the neuromuscular junction because you give a second dose, or because the plasma cholestases are inhibited, so succinylcholine is metabolized less. Okay, so this is kind of it will give you an idea about the A is a control. A is a control, so you can see the train of four. You have four twitches on the left-hand side, and then you have the tetanic stimulation, which is the whole twitches are fused in one contraction. We call it tetany because you give a supramaximal hertz, more than 30, usually you give 50 hertz, and then the one on the right side in figure A is the post-tetanic stimulation. Okay. So this is no muscle relaxant in A. B, there is partial depolarizing block, which is kind of succinylcholine. So the height of the twitch is low, okay. But the two things is there is no fade and there is no post-tetanic potentiation, okay, which is evident in graph C. So C is a non-depolarizing muscle relaxant where you see there is a fade in the train of four, and there is a fade in the tetanic stimulation, but there is post-tetanic potentiation. So after tetanic stimulation, you wait for 3 seconds, and then again you apply tetanic stimulation, you got post-tetanic potentiation. Okay, so these are kind of give you an idea about the twitches. Okay, so again, the pattern of the non-depolarizing muscle relaxant block again is increasing receptor occupancy. This is just to show you basically what we were just talking in terms of receptor occupancy. We said that we need really a very large receptor occupancy for the twitches to be reduced. Okay, you can see here there is 70% of receptor occupancy, but still the train of four count is 4. The T4 to T1 ratio is 1. The double burst is 1. And the height of the single twitch is still 100%. Okay, as the receptor occupancy increase, going to 80%, then there is a reduction in the height of the train of four. So the ratio became 0.75. So the height of the T4 to T1 is 0.75. So 3/4, T4 is 3/4 of T1. Okay. And then as the receptor occupancy increase, then the ratio is decreasing. So it became 0.5, then it became 0.25. And then once the receptor occupancy approaching 90 and just above 90, then T4 gone. Okay, and then as the receptor occupancy increase, you will lose one more, and then you will remain with only one twitch around 95% of receptor occupancy. Okay, there is a large safety margin in the neuromuscular junction. Okay, we are nearly there. Um, okay, so these are kind of just to demonstrate the phases of the neuromuscular block. So um, so always you have patient has to be anesthetized, obviously, to give muscle relaxant. Okay, so you cannot really give muscle relaxants in an awake patient. So, like if you follow with this diagram, so once you give this is the induction side, the far left, and I have cursor. Sorry. Okay, so once you give the muscle relaxants, then this is the pre-induction. So the 304 304 count is 4, 304 ratio is 1, and there is no fade. Okay, so you induce the patient, and the twitch will show like that. So 4 twitches, the ratio is 1, and there is no fade. Then once you give the non-depolarizing muscle relaxant, so the count is still kind of, it will progress from 4, but the T4 is kind of, now it became very smaller, shorter compared to 1. And you will lose then T4, and then you might lose T4 and T3, and then you will remain with 1. And this will go with fade as well. Okay, so this might be the time now for intubation. So you have a reduction in the train of 4 count and train of 4 ratio. Okay, so train of 4 is kind of important to kind of see the patient going to the depth of block. Subsequently, once the block is kind of very deep or complete block, then train of 4 will not be of use. Then you have to use the post-tetanic count, which you kind of appreciate the deeper block. Okay, so after induction, after intubation, then you will go to complete block. So this is goes with the time and the receptor occupancy by the non-depolarizing muscle relaxant. So in complete block, the train of 4 became 0 and the post-tetanic count is 0. Okay, then from complete, you will go to deep block where the train of 4 count is 0, but the post-tetanic count now is more than 1. So it start to kind of recover. Okay, and then you will go from deep block to what we call moderate block, where the train of 4 count start to appear again, and 1 to 3 block twitches is there in the twitch. So the moderate block. So it's kind of starting the recovery. This is during maintenance. So the middle blue graph is the during the maintenance. So induction, maintenance, and then the recovery. So once you come to recovery, then the block will become shallow. So the train of 4 now is less than 0.4, and there is fade in the wave. It goes to minimal block where the train of 4 is 0.4 to zero point 0.9. So it starts recovering. Okay, and you can see the train of 4 count is coming back. We have 4 twitches now, and nearly now the T1 is kind of more of complete now. Okay, still T4 is kind of small, maybe 0.50%, and then it will go to acceptable recovery time when the T4 ratio is more than 0.9, where you will kind of consider extubation. Having said that, the muscle behave differently in terms of their response to muscle relaxant, what we call differential muscle sensitivity and monitoring. Because this one, if you want to identify where you can monitor the these twitches. So where you apply your twitches, usually the larynx, diaphragm, upper abdominal, and corrugator supercilii muscle, they display relative resistance to neuromuscular block. Okay, so they block more slower than the other. On the other side, the rich blood supply ensure a rapid washing and washout. So they go into muscle relaxation very quicker and they recover also very quicker. But sensitive muscle like ocular, pharyngeal, they are slowest to recover. Okay, so they take time to recover, and you can see they are kind of the slower. So there's the quicker one, the diaphragm, the laryngeal muscle, adductor pollicis, and then you come down to pharyngeal and the masseter muscle. The adductor pollicis muscle response to ulnar nerve stimulation is the best to monitor during the intraoperative period because it simulates the sensitive muscles and it will give you a good indication of recovery of the laryngeal and the diaphragm muscle. While the posterior tibial nerve, flexor hallucis brevis muscle, they might be used, but the facial nerve and the eye muscle should not be used for monitoring. And if you use the facial muscle, then a very lower currents should be used for monitoring. So there is kind of, again, differential muscle response to muscle relaxants and neuromuscular block. Okay. We come now to the reversal agents, and this we will just take it very quick. Okay, now from the kinetics, from our knowledge of the muscle relaxants, to reverse those muscle relaxants, we need to increase the concentration of acetylcholine at the neuromuscular junction. And then the acetylcholine will take over and the muscle, the neuromuscular junction will be back to its normal function. Acetylcholine is metabolized by the acetylcholinesterases. So in essence, we need to give anticholinesterases to increase the concentration of the acetylcholine. However, anticholinesterases usually should be given with an anticholinergic agents like atropine or glycopyrrolate to prevent the incidence of bradycardia and excessive salivation. Don't worry about that one, but for general, the mechanism of action usually it will be in three categories: easily reversible inhibition like hydrophonium, formation of a carbon-related enzyme complex that's neostigmine, which we will be interested in that one, and the irreversible inactivation like the organophosphorus. This kind of more of academic knowledge really, but the hydrophonium is important in terms of myasthenia gravis and myasthenic crisis and these kind of things. So it interacts in that sense. But our interest is neostigmine. Neostigmine is a quaternary amine and it's presented as tablet or in solution for intravenous injection in combination with glycopyrrolate. Usually it will be formulated with glycopyrrolate, as we said, to prevent against bradycardia and excessive salivation. We use neostigmine for reversal of non-depolarizing muscle relaxants, and it's usually given in different doses, but generally 0.05 mg per kg intravenously. And again, it is used also for treatment of myasthenia gravis and in urinary retention. So neostigmine may precipitate bradycardia, okay, because it increases the concentration of acetylcholine. It also might precipitate bronchospasm in asthmatic, okay. It might increase salivation and intestinal motility. It has a very low oral bioavailability. It's very minimal protein bound, low volume of distribution, and 55 is excreted in urine and change. The other major reversal agent is sugammadex, and sugammadex is kind of licensed only in 2008 in Europe, and in US in 2015. So it took the US 7 years after Europe to license Sugammadex because of the fear and concern about sensitivity reaction to Sugammadex. It is a gamma cyclodic strain and is sometimes referred to it as a selective relaxant binding agent. It is presented as a 100 mg per ml solution in 2 or 5 ml vial. The dose required depends on the depth of the neuromuscular blockade, as we'll see shortly. And the shelf life is around 3 years. Okay, so Sugammadex, we will see in a minute. It is given either in 2 mg per kg, 4 mg per kg, or 16 mg per kg based on the level of the block. So what Sugammadex does, it selectively encapsulates amino steroidal non-depolarizing muscle relaxant like rocronium and vecronium only. It doesn't affect benzyl isoquinonium and remove them from the plasma and the neuromuscular junction. The volume of distribution is around 11 to 14 liter. It has a linear kinetic at therapeutic doses. It's not metabolized, so it's kind of the complex between Sugammadex and rocronium or vecronium is excreted solely via the kidney with an effective half-life of 2.5 hours. There is lots of hypersensitivity concern about Sugammadex, but Sugammadex also sometimes is used in rocronium-induced hypersensitivity, although it is not part of the kind of recommendation for treatment of rocronium hypersensitivity, because there is lots of concern about its own induced hypersensitivity reaction. So we are coming to conclusion, but some of the practical tips really in the reversal agents, you have to know about the kinetics of the muscle relaxant in relation to the nerve stimulation or train of 4. If you can look to this one, you can see the yellow part, kind of the receptor occupancy. So the receptor occupancy is kind of, it increased from 25 to 75, but with that much receptor occupancy, still we have a train of 4 of 0.9, if you can see the graph clearly. Okay, and this will give you kind of an indication for the reversal agents, because you have really to time it with your nerve stimulation, either train of 4 or post-tetanic count, to understand how much block you have, and then that will kind of give you an indication about the dose of either neostigmine or Sugammadex, but more of Sugammadex. Neostigmine generally has a ceiling effects, so it has a very slow antagonistic action, and it requires a high level of spontaneous recovery to guarantee safe and complete antagonism. So you have to wait for spontaneous recovery before giving Sugammadex. Otherwise, it will not work. Like if you want to antagonize a minimal block, that is a train of 4 is more than 0.4, then the recommended dose might be around 30 mg per kg. Okay, and that will take maybe 10 minutes for recovery. But for a moderate block, that's a train of 4 count of 1 to 3, or a shallow, which is kind of a train of 4 ratio less than 0.4 block, then neostigmine reversal time might be very long, might be up to 30 minutes actually, and you might need a 50 per kg compared to when you have a train of 4 of more than 0.4. So you have, generally, to reverse with neostigmine, we will wait for a train of 4 ratio of more than 0.5. Okay. Okay. In terms of Sogamadex, then the manufacturer generally recommend that reversal dose 16 milligram per kg when the post-tetanic count is 0. That is a deep block, and that will be a rescue reversal in terms of suppose you give recronium and you find whatever difficult intubation and you want to reverse the muscle relaxation as quick as possible, then you will give 16 mg per kg. You could give a 4 milligram per kg if you want to for a deep block like that post-tetanic count of 1 to 2, and 2 milligram for moderate block that is a train of 4 of 2. Okay, so we're coming to the end, and I will conclude saying that the muscle relaxants are mostly used to facilitate endotracheal intubation. That's kind of the general concept, but also we use it for lots of other things in intensive care, and we also use it to improve the operative condition. You must have a strategy for managing neuromuscular block as part of a balanced anesthesia technique. Neuromuscular monitoring is advocated when using muscle relaxant. When you use muscle relaxant, you have to monitor neuromuscular blocking. Okay, so you really need to use muscle relaxant when you need them. That is number one. And when you use them, you really need to monitor them. Residual neuromuscular block is something very distressing. So you try your best to avoid that one by using the muscle relaxant when indicated, and monitor the patient when you use it. Generally, residual neuromuscular blockage is very widespread, but it is really unmeasured and unseen. Okay, thank you very much. And these are some of the references, so you might consult them if you need kind of more information. Thank you.
شكرا جزيلا. Very comprehensive يا عثمان. Very very tough topic.
It is too long.
Yeah, no, but you nailed it anyway. And it's good that now the trainees, they can at least, they can find the whole topic in one area. This is actually very good. It is challenging for the presenter, but it's very good for the audience. So thank you. I think you did justice for
Thank you.
a very tricky topic. طيب لو في أي أسئلة. Okay, ده أول سؤال يا عثمان. Kindly, what do you mean by 4 and 9 regarding train of 4? And when we can give reversal again regarding that? Thanks. أنا ما عارفة قريتها صح ولا لا يا محمد عبد الله. لو أنا ما قريت السؤال صح أنا ما فهمتها. قصدك 4 and 9 دي الريشيو يعني، ولا you can unmute and you can say your يعني you can like say your question بطريقة صحيحة. عثمان لو فهمت السؤال just يعني.
I just push this one back if possible, the other slide. Actually, this is a very good slide.
Okay.
And probably the question is about when to give reversal. So probably the last slide kind of summarized this one in terms of, so if you have this quantitative monitor, then you really need to consult the monitor before you give the reversal agent. Neostigmine, usually you have to have some spontaneous recovery before you use neostigmine, because otherwise it will not work. Okay, so the minimum block, so if the train of 4 is more than 0.4, generally I would say, then only you can give reversal. Okay, and what you need is a train of 4 is more than 0.9 for recovery. Okay, and in terms of Sogamadex, then the story is different. Sogamadex is kind of very predictable, and you can give it, and it depends on the dose. So usually we go with the dose of 16, 4, and 2. So immediate reversal, you will give 16 mg per kg, which is a very large dose. If the post-tetanic count is kind of between 1 and 2, then you can give 4 mg per kg. And if the train of 4 count is more than 2, then 2 mg per kg is enough. So what I'm saying, the post-tetanic count, you use it for a deep block. So when we are saying or assessing the post-tetanic count, that means the deep is still, the block is still deep. Okay, but generally, a train of 4 of more than zero point 0.4 will be your target to give the reversal agent.
هو قصده 0.4. أنا قريته 4 ما فهمتها. أوكي. what's long story short يا محمد إنه you cannot reverse كلام دكتور عثمان إنك you cannot reverse deep block with newstigmine.
Yeah,
النيوستجمين ما ممكن تستعمله ل rescue reversal.
yeah,
لازم البلوك يكون started to recover.
correct.
دي الثورة الكبيرة اللي حصلت بعد ما إنه السوجاميدكس جاء للماركت، لأنه بقى في إمكانية ريفرسال دي بلوك. في سؤال تاني يا عثمان regarding uh, pre-treatment with small doses of neuromuscular blocker before sex to
Yeah,
prevent adverse effect.
yeah,
قال
yeah.
لك is this a common practice?
Oh,
And
oh,
what is the time interval يعني بالضبط for
yeah.
such practice?
Wallahi, I never use it, to be honest, um, because I think we are in the era of prochronium now, so it's kind of succinylcholine is very less used at the moment. But yeah, some people they give a very small dose of non-depolarizing muscle relaxant. So the fasciculation and the pain, muscle pain, and those go all from the pre-junctional acetylcholine receptors. So if you block those ones with a non-depolarizing muscle relaxants in the beginning, so it's kind of method just before giving succinylcholine, you will give a small dose of non-depolarizing muscle relaxant that they would say. I'm not sure, or I didn't come across really a large study to kind of conclude that this is something work or doesn't work. But in clinical practice, it works. People use it. Yeah, lots of people use it, and but it's not something that you can really prove because it is kind of the practice is not that large or very common.
شكرا يا عثمان.
لكن
I have to
I think
echo.
succinylcholine also is
Mm.
it's important also not to give more succinylcholine. That is also very important, and to identify patients who are not suitable for succinylcholine. That is also very important because you get very detrimental effects from succinylcholine. Uh, these kind of things is okay. It's very distressing, very bad. The myalgia and the muscle pain, but other detrimental things like potassium and these kind of things are really serious.
Okay, I agree with you. هو ساكسينايل ده بقى زي الأوبسوليت ميديسين. يعني حتى احنا عندنا في الأوبستاتريك although الكلاسيكال رابid سيكونس induction هو يعني الساكسينايل كولين is a core drug فيه،
Mm.
لكن now we use روكرونيوم. يعني كل المودرن اوبستاتريك انستيزيا ما فيها ساكسينايل كولين،
Mm.
لأنه المشاكل بتاعته يعني لو الكومبليكيشنز بتاعته خطيرة يعني، وما بتقدر إنه تجازف بيها في vulnerable group.
Yeah, yeah.
أوكي، في أي سؤال تاني؟ نختم على كده. عثمان أصلا الليلة مسكناك أنت وخالد كده. قبل ما أفككم جاء سؤال. أنا هاخد ده as the last question يا جماعة، معلش. how can we manage post-operative residual colorization if it
Yeah.
occur?
Yeah. Yeah, that is
or
that's
even
actually,
after reversal administration. منو اللي سأل السؤال ده؟ هنيدة. Thank you. Very good question.
yeah, it's very good question. Yeah, residual block is something very distressing. I think no anesthetist want that one to happen to any of your patients. Um, it is very detrimental. So it's kind of really you have to manage accordingly. But if the patient is not, so you have some kind of objective measures of whether the patient is still under the effects of muscle relaxants or not. I mean, clinically, the hand grip, lifting the head, these kind of things are all important. But if you are sure that the patient still is has a residual block, then you have to anesthetize the patient. That is the most important. The worst scenario is an awake patient and who cannot breathe. So that is kind of very distressing. And so you have to sedate the patient, maybe waiting for the muscle relaxant to wear off. And you see, even after uh, kind of recovery of more than, I really recommend you guys to go through those references. They have lots of kind of clinical information and evidence-based discussion about these things. I just didn't include them because I want to keep the topic as basic as possible. But for your sake, just maybe have a look to those references. They are very good, and they will kind of enlighten really your knowledge about muscle relaxant and related to the clinical practice. So for this question, yeah, you need to manage, you need to sedate the patient, anesthetize the patient, and then wait for the muscle relaxant to wear off. If you have a muscle relaxant to be reversed by newstigmine, then you need really for the train of four to come more than zero point 0.4 and then give a reversal again. Obviously, newstigmine is always, as we said, mixed with glycopyrrolate to avoid the bradycardia and salivation and these kind of things. If you something to reverse with sugammadex, I mean a minor steroid, then sugammadex may be more predictable, so you can use that one. So yeah, I think this is kind of the thing you need to do if you encounter such. I hope not.
I agree. المهم هو يا هنيدة، يعني بس يعني use your clinical sense زي ما قال دكتور عثمان. assess البيشنت، لو في أي signs إنه البيشنت is partially paralyzed treat accordingly. إذا هو paralyzed بالروكرونيوم الموضوع بيكون سهل، بتدي سوجاميدكس. لو paralyzed ب other muscle relaxant you have to make sure that the patient is sedated. في مشكلة برضو في intensive care patients اللي بنديهم muscle relaxant وبنديهم light sedation. دي طبعا من أكبر الجرائم اللي بتحصل.
Yeah,
أي patient بياخد muscle relaxant should be anesthetized ما sedated. anesthetized يعني أنت لما تدي muscle relaxant البيشنت حقك ما تحطه في light sedation، لأنه ما في حاجة يعني أفتكر إنك يعني مؤلمة أكتر من إنك تشيل إنسان وما تنومه. So always remember this. يعني muscle relaxant معاها anesthesia طوالي، دي ما فيها يعني دي ما ده ما ذكاء إنه الواحد يشيل إنسان ويديه لايت سيديشن، يقول كده خلي العيان قريب. انت التروما اللي ممكن تحصل للمريض بعد ذاك يعني بتكون يعني هنا dangerous.
yeah.
افتكر نختم بعد ده يا عثمان، عندك اي تعليق؟
Tamam. No, thank you very much. Yeah, it's kind of it's an important topic, and you really need to know about it very well for those who are kind of doing the exam, or for those who finish their exam and they want it for their
Yeah.
clinical practice.
Thank you very much. I also echo what دكتور عثمان said. في معظم الامتحانات الأخيرة اللي كنا فيها ده كان سؤال ثابت. يعني الاسسمنت بتاع البلوك، انه how to differentiate between السكسينايل كونين والother مثل relaxant in term of agonist antagonist how to reverse. المهم ده كله you have to go through it. افتكر ده المحاضرة دي هتكون مرجع كويس لكم. خالد شكرا. Thank you very much. I think by this we reached the end of our lecture. شكرا جزيلا. We can stop the recording now. Thank you very much.